Thank you very much. Well, I'm going to tell you about the burden of disease and the unmet need in patients with refractory chronic spontaneous urticaria. That means patients who don't respond well to treatment. These are my disclosures. Let's start with definition and classification of urticaria. At the International Consensus in Berlin, held in 2012 and published this year, chronic urticaria was defined as a disease characterized by spontaneous itchy wheals, angioedema, or both, for 6 weeks or more, with known or unknown causes. Very simple. And this is the sort of working pattern I want you to think of when patients come into your clinic. How do you classify patients when they sit down and talk to you? We know that the majority will have spontaneous urticaria. It may be acute, it may be chronic. Some will have inducible urticaria, induced by different stimuli. And there's an overlap between the two, so patients may have both spontaneous and inducible. We know that some patients will have angioedema without wheals and still be spontaneous. So about 10% of patients with spontaneous urticaria present with angioedema. But there will be others who present without wheals who have hereditary angioedema, completely different illness, different treatment, different illness. And we know that urticarial vasculitis overlaps in clinical appearance, but you can distinguish it from chronic urticaria by skin biopsy, by finding vasculitis on biopsy. We know that some patients will have contact urticaria, and just a few will have autoinflammatory syndromes. These are different illnesses, different treatments. And in the latest consensus classification, contact urticaria drops into inducible, and that makes a lot of sense. Let's look at the prevalence. I'm asking the question, is it really known? Because estimates often fail to distinguish between point prevalence, the prevalence at this moment, today, against lifetime prevalence. In other words, over your whole lives, are you going to get urticaria? Or cohort prevalence, such as in children, adolescents, students, or adults. And there will be variation by country, and primary versus secondary care, etc. And it's important to distinguish between acute and chronic disease, spontaneous and inducible. So here is some data, but they are estimates. About 18.7% of patients presented with acute urticaria have this lifetime prevalence at some stage over their lives. Looking at another survey, which was an internet survey, only 8.8% declared acute or chronic eczema at some time over their lives. And if we just restrict to chronic eczema, we can see that it was 0.6%, quite a low proportion out of all the spontaneous urticarias, and in the Berlin survey, it was higher. If we look at point prevalence, urticaria today, how many people have got urticaria today? Well, there's some old studies, but I like them because they're good, they were very thorough. And it suggested that 0.05% of patients had acute or chronic urticaria at any point in time. It was a little bit higher in a Swedish study. And if we look for chronic urticaria point prevalence, it was 0.8%. So we can see there's a spread of figures here, but one thing they all say is that it is relatively common. Now, the female-to-male ratio is 2:1, and I think that's everybody's experience. All age groups can be affected, but the peak incidence is between 20 and 40 years of age. So this is a difficult question, but just think about your own country. What is the estimated prevalence of chronic spontaneous urticaria in your country? So you have these 5 options: 0 to less than 0.5, 0.5 to less than 1%, 1 to less than 2%, or more than 2%, or you just don't know. So get voting. Well, that's honesty for you. A lot of you just don't know. And I understand that. But I think the majority of you agree with what's published. It's about 0.5 to 1%, so well done. It seems like if we represent an international audience, we have consensus. Let's look at duration of chronic spontaneous urticaria. This figure on your left shows 50 patients at baseline. Patients initially diagnosed with chronic spontaneous urticaria. And then we know that 50% will continue to suffer after 6 months. 50% are better, 50% are still suffering. If we look at 3 years, 30% will continue to suffer. 70% are better. And if we look at 5 years, 10% will continue to suffer from the symptoms of chronic spontaneous urticaria, and there are a few who will continue for much longer. So it does have natural improvement, natural resolution occurs, but it can be a long time, and we cannot say to our patients when they sit in front of us when that will be. Remember that 50% or more will experience at least one recurrence of symptoms after an apparent resolution. Now, studies suggest that although the duration of chronic spontaneous urticaria is generally 1 to 5 years, there is evidence that it is longer in patients with certain additional features. More severe disease, concurrent angioedema, concurrent inducible urticaria, particularly delayed pressure, or a positive autologous serum skin test, if you're doing those. This is the next question, probably easier to address. What is the longest duration of urticaria in a patient with CSU that you have treated? So think of the longest that you've ever come across in your clinic. 6 months, 3 years, 5 years, 10 years, or 20 years or more. Voting, please. Okay, so a few people have seen patients for 6 months. That's a long time for a patient with urticaria. But look at the number who've seen patients who've had urticaria for 20 years or more. I think this reflects our interest in urticaria as dermatologists, that we see these difficult patients, and these are the ones we have to focus on especially. So there is an unmet need in this group. Overall, studies suggest that first-line therapy with a second-generation H1 antihistamine at the licensed dose will lead to symptomatic improvement in about 50%. So about 50% of chronic spontaneous urticarias remain symptomatic with H1 antihistamines at the licensed dose. Now, it's recently become popular to increase above license, above label, up to 4-fold in the guidelines. And still, up to 1/3 of spontaneous urticaria patients will remain symptomatic. So we have an unmet need. Let's talk about burden of disease. What does it really mean? Well, there's a significant burden for patients with inadequately controlled chronic spontaneous urticaria. Sleep deprivation due to itch impairs the patient's health-related quality of life, physical and emotional well-being, work performance, and social functioning. All of these are factors that lead to impairment in quality of life. And patients with chronic spontaneous urticaria also have comorbidities such as depression and anxiety. So there have been positive correlations shown between itch intensity and the severity of depression. CSU patients had higher Beck depression inventory and Beck anxiety inventory scores than healthy controls. And also psychiatric comorbidity significantly increased quality of life impairment. Studies suggest patients see an average of 2 physicians before being referred to a specialist, which may, of course, delay diagnosis, but importantly delay appropriate treatment and extend the disease burden. These are 2 studies. The first demonstrated that approximately 69% of CSU patients are not referred by their general practitioner to specialist tertiary care centers, and that was a German study. And also that this is important because specialist dermatologists are more aware of the management and treatment guidelines for chronic spontaneous urticaria. So you can see that the proportion of dermatologists who said that they were aware of guidelines was over 50%. GPs, quite low, pediatricians in between, and all physicians together, still relatively low. So awareness of guidelines will guide our treatment. There are many aspects of quality of life that are reduced in patients with CSU, with the presence of angioedema further impairing the quality of life scores. Daily living, physical activities, chores, eating, concentrating, and sleeping. Tiredness, being stressed, overwhelmed, and anxious. Impact on relationships, including sexual relationships. Restricted choice of clothing, limiting hobbies, avoiding sun exposure. Effect on everyday activities, the financial burden of the disease mustn't be underrated. Discomfort. And, loneliness, conspicuousness, anxiety over the future, feeling unhygienic. We wouldn't really think of this, but these are thoughts that patients will have. So it does emphasize the many-faceted quality of life impairment. This was one of the first surveys, and it was the Nottingham Health Profile that was given to patients with chronic spontaneous urticaria. And you can see that there were different domains of swelling, itch, pain, feeling tired, unpredictable attacks, social restrictions, feeling embarrassed, time off work, food and clothing restriction, drug side effects, unable to relax and sit. And you can see that swelling was really the highest domain, the highest proportion of patients noted that. And itch was close behind. And of course, pain and itch are very similar. It's quite hard to separate what pain is sometimes or what itch is. It can be both. And I reckon that these will help to increase the feeling of tiredness and the time off work resulting from that feeling of tiredness. So the symptom leads to the outcome. It's good to have studies that compare different dermatology diseases, because where do we place chronic spontaneous urticaria in all of this? Well, here's a French study using the VQ Dermato, French quality of life instrument, to compare chronic spontaneous urticaria with psoriasis and atopic dermatitis. We all know how itchy and distressing atopic dermatitis can be. We know how bad psoriasis can be. If you look overall, in fact, they're not dissimilar across these different domains and dimensions. But this particular one, daily living activities, you can see chronic spontaneous urticaria is more impairing than psoriasis. And we look at physical discomfort, it is more impairing than psoriasis. And I think that's interesting. It's not intuitive. There is a socio-economic burden as well of refractory CSU. It's high in terms of direct medical costs and, of course, indirect costs such as lost wages because of absences from work. This is a US study that is the only one that's in the public domain. New data are coming through, and I hope that those can be shared with you. But the direct costs you'll see are mainly medication. Laboratory costs, very little, because we don't do many investigations for CSU, but medication costs account for a lot of that. An indirect cost, now these are different y-axes, the scales are different, but just to show you the proportion that there is, in fact, absence from work is really important as an indirect cost. So in summary, CSU is defined by spontaneous itchy wheals, angioedema, or both, for 6 weeks or more, with known or unknown causes. CSU is a common illness, but the exact prevalence is uncertain. CSU is self-limited with a duration of at least 1 year in some patients and 5 years or more in others. Disease severity impacts on the duration of symptoms in some patients. H1 antihistamines do not control symptoms in all CSU patients. And patients with refractory CSU have a significant disease burden, and CSU has a high socio-economic impact. Thank you for your attention.